Hi, and welcome to the presentation on CBD and THC in oncology. I'm Clay Jackson. I'm the Director of Palliative Care at the West Cancer Center in Memphis, Tennessee, and I'm an Assistant Clinical Professor of Family Medicine and Psychiatry at the University of Tennessee College of Medicine.
I'm Katie Parker. I'm a nurse practitioner with our palliative care team at West Cancer Center.
So what are our objectives today? We want to describe at the end of this presentation, we want you to be able to describe the purpose of the endocannabinoid system and some of the physiologic effects of select cannabinoids. We'll review some of the clinical indications, dosing considerations, and limitations for use of cannabis in patients with cancer. We'll identify some state and fed legislative and regulatory issues that are associated with medical cannabis use and how those can impact your patients, their families, and your practice. And finally, we'll compare strategies for communicating with cancer patients about cannabis therapeutics, because obviously it's very popular with patients and it's something that they want to know about. So let's begin with the basics. What are the cannabinoids and what do they do? You have on the leftward portion of this slide sort of a cartoon of a synaptic cleft. You have two neurons here. They're reaching out with the dendrites to connect and to send neurotransmitter information. So if we blow that up on the right side of the slide, you'll see at the top a presynaptic neuron and at the bottom a postsynaptic neuron. You see the classic neurotransmitter vesicles on top. They're releasing neurotransmitters into the synaptic cleft to have some sort of effect on the postsynaptic neuron. This is classic sort of theory of 1990s era CNS or central nervous system physiology. What you see is that the cannabinoid system, CB1 and CB2 receptors, cannabinoid 1 and cannabinoid 2 receptors, are basically a retrograde allostatic signaling control. What does that mean? It means that basically cannabinoids exist to sort of, if the body's moving too fast, to slow it down, if it's moving too slow, to speed it up, because they're a retrograde allostatic system that sort of promotes homeostasis. And we can use exogenous compounds to take advantage of this endogenous endocannabinoid system. Here's a very ugly slide. It also has a few builds, I believe. It basically shows you on that sort of, we've blown it up again, that presynaptic vesicle at the top. You're seeing that cannabinoid 1 receptor, and it has endogenous ligands, and then THC is a partial agonist, as well as CBD is an inverse agonist at CB1. These compounds also have other effects. You'll see down at the bottom, the postsynaptic vesicle, that there's reuptake inhibition. Again, this is an allostatic system. There are endogenous agonists. There are internal molecules such as FAAH and MAG that actually degrade these endogenous agonists. So it's a very complicated system that's designed to keep an equilibrium in the body. TRPV1 is a vanillin receptor that is basically involved with pain control. You see at the rightward portion of the slide at the bottom, there's direct 5-HT1A agonism, and this is involved in anxiolysis. This is basically the way that buspirone works as a pharmacologic agent. CBD is a 5-HT1 agonist. It makes it a decent anxiolytic. And then also it has some allostatic control with pain. Let's summarize it by saying that CBD and THC both have multiple targets. This is a complex system of equilibrium, homeostasis, and allostasis. And therefore, pharmacologic influence on this system gets complicated because it's a pinball machine. There's lots of moving parts, and it's not just a simple ligand and receptor phenomenon. Why do we have an endocannabinoid system? Well, you'll see 4 areas: relaxation and sleep, memory and forgetting, appetite regulation, and pain modulation. These all have to do with stress. Let's take the extreme post-traumatic stress disorder or PTSD. What might happen? You can't sleep, you can't relax. You'd love to forget and you can't. You've got rumination. Your appetite's off, too little or too much. And then you could even have inflammation and pain in your body. This is where the endocannabinoid system, for instance, might alleviate some of that stress and could cause you to have homeostasis or an allostatic response. Now, weed, as it's grown, is complex. It has 554 phytochemical compounds that have been identified in native cannabis. The terpenes make it smell bad or inviting, depending on your taste. For my palate, they smell bad. There's flavonoids and ligands that are involved. Steroids and enzymes, which makes it an anti-inflammatory agent. It's quite good as an anti-inflammatory agent, but we'll see that may have some challenges for those of you who are providing anti-neoplastic therapy. In the upper right-hand corner, we have 113 cannabinoids. CBD and THC are the main ones, but there are other ones involved. So if somebody tells you, hey, I was smoking weed and now you prescribe me Marinol, which is basically purified THC, and that's not working, well, maybe it's not, because there are 553 other compounds they were getting in their Cheech and Chong stuff that they're not getting in your Dronabinol or Marinol that's being prescribed. So what's legal, what's approved, and what all of our patients doing? Well, this is a 2021 map. This shifts fairly quickly with each election cycle. You'll see 3 states in the Mountain West and Midwest that don't have any policy. Most of the United States is green, indicating that there's some sort of legalization of marijuana products. Some of them are medical. You see that further out west and on the upper East Coast. And then in sort of NASCAR country, it tends to be CBD only and not THC. But then there are other states through the Mississippi River Valley Basin that also have THC programs, which is what you see in that sort of Kelly green. In terms of FDA approved products, we have Dronabinol, which we've already mentioned, that's Marinol. It's approved for CINV, or chemotherapy-induced nausea and vomiting. It's approved for anorexia. Syndrose is approved for anorexia. Nabalone, Casomet, that's approved for CINV alone. There is one CBD product that has FDA approvals for pediatric use in rare seizures. There's a combined product that's approved in the UK and Canada. It's in phase 3 trials here. It's called Sativex or the Biximols, and it's a THC CBD mixture. What are your patients doing? They're taking gummies instead of opioids. They're taking gummies instead of Xanax. They're taking gummies instead of Prozac. This may be good, may be bad. It may affect your therapy in certain ways. Some people have thought that people with pain may substitute weed, and that might be salutary to sort of solve the opioid crisis. It's not that simple, and we'll see that as Katie presents some of our data in a moment. Here's the structure of THC. Basically, it has pain properties, anti-inflammatory properties, antiemetic properties, antispasmodic properties, but it does cause sedation. And not all of these properties can be controlled clinically. CBD is antipsychotic, it's anti-epileptic, it's antidepressant, it's anxiolytic, and it does provide some analgesia. Well, THC makes you high, it's psychotomimetic. CBD is actually not non-psychoactive. It's psychoactive, but like coffee, it awakens you and changes your mind. It doesn't cause psychosis. THC can be dependency forming, no matter what else you might have read. CBD is non-intoxicating. THC is angiogenic, whereas CBD counters that. THC disrupts intellectual development. CBD has been touted as panacea, but it's not quite so simple. THC is not the devil, and CBD is not an angel. Let's take one look at one of the complicating factors that accompanies cannabinoid pharmacology, and that is that there's a biphasic dose-response relationship with respect to THC products. And that means in the serum that if you don't have much in your bloodstream, basically you don't get an effect. And then the symptoms go down in a parabolic fashion. But if you overdose, they start to go back up. So this dosing is quite complicated because more is not always more. Sometimes more is less because the symptomatology that you're trying to treat actually can increase. One classic example of this is emesis or nausea, whereas THC may be effective at lower doses or mid-range doses. If you take too much of it, it causes hyperemesis, and we've seen a rash of emergency department admissions for just that problem. Let's take a look at CBD and how it's delivered in different products around the country. Oral, inhaled, and transdermal. Oral is about 20% bioavailability, inhaled is about a third, and transdermal is anybody's guess. There are some drug-drug interactions that are important. CBD inhibits conversion of tamoxifen by the 2D6 cytochrome pathway. And so if you're actually treating patients with ER-positive breast and you've got them on tamoxifen and they're taking CBD, then they may be getting less than a benefit of their hormonal therapy. Many of your chemotherapeutic agents can be increasing concentration because CBD actually causes CYP3A4 inhibition, and so concentrations may go up with adverse events. And so with that, we've talked a little bit about the theory. Katie, I think you've got some data on some studies, and you're going to tell people whether Susan Sarandon in the movie Stepmom was just smoking to be cool or to get high, or whether actually she was in the forward cusp of symptomatic therapy for those with cancer. Show us the data, Katie, and tell us whether this stuff works or not.
Absolutely. So as Dr. Jackson said, let's take a look kind of by symptom, how well or not well cannabinoids have been proven to work. So the first thing we're going to look at is pain, and about 70 to 80% of advanced cancer patients report pain. So this is for sure something that if cannabinoids worked would be a wonderful benefit to your patients. So this was a retrospective study that was done in a palliative care clinic, and they had patients come in and they did a urine drug screen. Based on their urine drug screen, whether they did or did not have THC in it, they looked at symptom assessment scores. They compared those based on whether they had the THC or whether they didn't. And interestingly enough, the people that did have THC in their urine actually reported higher symptom assessment scores than those that didn't. They had more pain, more nausea, more insomnia. So if you're just looking at it at surface level, it seems like, well, that seems silly. It's clearly not helping. However, this didn't really give us a good understanding of were the people that were using THC, did they already have a higher symptom burden? So this doesn't really give us a huge insight into it, but it does give us a clue that maybe it's not exactly what we think it's cut out to be. There was another study that looked at the nabiximols, which is the regulated product, and they looked to see whether it had any impact on pain scores. And in fact, they found no difference. The people that were taking the nabiximols didn't have any improvement in their pain as opposed to the people that were taking a placebo. Interestingly, though, the people that were using the nabiximols had a higher risk of harm. So they had more somnolence, more dizziness, and depending on your patient population, that could be a significant concern. So just something to keep in the back of your head.
And this is a rather large meta-analysis of 5 different trials. This was randomized. It was not a retrospective study, 1,400 patients. And again, this was the one that's available in the UK and Canada and is in phase 3 trials here. It's the mixed product of THC and CBD.
So a lot of our patients tell us, well, I really need that weed because I want my appetite to be better. So it doesn't really help. So there have been multiple studies that have shown that, in fact, it really doesn't seem to. It doesn't improve appetite or caloric intake. It doesn't really affect their weight loss or gain. And in a head-to-head study with Megastraw, it actually failed. The Megastraw was superior in increasing the appetite, improving body weight, et cetera. So really, with the little data that we have, recommending a THC product or a CBD product for weight gain would really be a very low third line option at best. It would be much wiser to use other options first.
I think so too, Katie. I think a natural question comes up, well, if it doesn't work for anorexia, or how to get approved. And I think this is the difference between registration trials, which are very carefully controlled with a very select patient population. If you're a pharmaceutical company, and many of you participated in pharmaceutically funded research, those are very carefully managed trials. These trials actually are post-marketing trials and sort of real world external validity cases where it shows with sort of real world patients without all the exclusions. It just doesn't work that well.
And so as you may have guessed how this might go, it also has not been shown to be very helpful with nausea and vomiting. It really didn't show much improvement. There was a mild difference between the cannabis product and a placebo, but it didn't really seem to do, it wasn't a game changer, let's say. And again, thinking back to that other study where there was an increase in somnolence and dizziness, you just want to be careful because these medications or self-medicated products do come with a fair amount of risk along the way.
That's what we mean by that narrow therapeutic window. It might help some people, but it could also cause some harm.
So does it help people sleep better? Nope. The cannabinoids did not show any improvement or difference between the placebo. So this gets back to that question that we were just talking about. So in general, it doesn't really help many people, as we've shown. And for the most part, it doesn't harm people. So it doesn't, while it doesn't actually improve quality of life metrics per se, it doesn't necessarily come with significant adverse effects. However, again, that does depend on the population that you're dealing with. If it's, you know, an 85-year-old little woman, that may be more of a risk than a younger person. There are a few populations that might be of benefit, and the head and neck cancer patient population is certainly one. They have a very high symptom burden. We see this in our clinic. They come in with lots of issues, pain, anxiety, depression, appetite, et cetera. And so there have been some studies that in this particular population, THC and marijuana has been helpful.
I found this clinically as well to be the case that head and neck patients do respond to cannabinoids. Also might add that HIV patients tend to respond well to cannabinoids. And so if you have an HIV-associated sarcoma, for instance, or an anal cancer associated with HIV positive patient, that cannabinoids might be helpful.
And then can it be more harmful than just what we talked about with somnolence or dizziness or, you know, whatnot? And perhaps there has been a study in Israel that looked at patients that were being treated with immunotherapy. And remember, Dr. Jackson mentioned earlier that there's some immunologic inhibition that happens with the THC and CBD. And so they looked to see, did that impact people that were receiving immunotherapy? And what they found was that the response rate to the immunotherapy was reduced in the people that had used cannabis. I believe, correct me if I'm wrong, Dr. Jackson, it also showed that there was a higher recurrence rate in that same population.
Yeah, so this is one of the studies that really gives us pause. And our personal recommendation at West is if anyone is on immunotherapy, we do not recommend any type of cannabinoid product, either CBD or THC. So what should we tell our patients about THC? As the evidence accumulates, the promise of the panacea has basically gone up in smoke, pun intended. The widespread popularity of THC containing cannabis products appears to be driven not by efficacy, but possibly for a desire for the psychotomimetic effects, sort of getting high, maybe a distrust of the modern medical model. So, you know, big pharma bad, Mother Nature good. You can think about THC basically in most populations as essential oils that get you high. There are some FDA-approved indications for anorexia and CIMV. However, Katie showed you that data in post-marketing studies has not stood up to real-world patient problems in populations. There are probably other medications that would likely work better at a lower cost. She gave an example in nausea for anorexia for megestrol. The cognitive, anxiolytic, psychotomimetic, and intoxication risks of THC are not negligible. Well, what about CBD? Our database of clinical studies is limited in number and in scope, and it's largely focused on CBD doses that are larger than those that are commonly available in the commercial products. There is a single product, cannabidiol, that has limited indication for seizures in pediatric patients, but that's not really applicable to most of our patient populations in adult oncology. CBD will probably remain largely a folk medicine. The marketing exceeds evidence by a long shot. And like THC's essential oil that gets you high, you think of it that way, CBD is probably essential oils that don't get you high. So there you have it. You want to avoid either or. Thinking about CBD, it can be a complement to existing medications. Some patients do like to use it, and you don't want to deny that if they're not at particular risk. So what populations would you want to avoid it in? Again, Katie told you immunotherapy, and I told you anybody who's on tamoxifen you'd want to avoid. And then think about your medications that are metabolized through cytochrome P450, easy to say. Yeah, CA3A4, then those medication concentration might go up. You expect more adverse events. Start low, go slow, self-titrate, and gather data. And remember that parabolic dose response biphasic curve. Avoiding a significant THC dose, so less than 0.3%, will reduce the cognitive, anxiolytic, psychotomimetic, and intoxication risks that attend THC. THC is psychotomimetic, it's cannabinoid. It has some efficacy for nausea, potentially for anorexia. It can reduce chronic pain slightly, but it's not been shown consistently to reduce cancer-related pain or other symptomatology or to improve quality of life, as Katie showed you, pardon the pun, ad nauseum. CBD is non-intoxicating, but it is psychoactive, makes you more alert, less anxious. It's cannabinoid. It has multiple mechanisms of action and could potentially lend well to multiple indications, such as social anxiety. But the claims exceed evidence, and it's not even close. Cannabinoids tend to show that biphasic dose response. More is not always better. The therapeutic window is narrow, and the harms are real. There are multiple approved products, and they may begin to clear the clinical picture, but perhaps not for some time because stuff's confusing. The study doses of THC are low compared to wild-type cannabis that's available in the contemporary scene, and the study doses of CBD are high compared to the available products. So with that, Katie and I want to thank you for your kind attention, and we wish you well in treating your patients in this jungle out there that is cannabinoid therapy at this time.